I welcome you all today for this ACNS Win webinar. And of course, Professor Kato is here. And I think all the speakers are here. Sharon will be joining me shortly. And the first talk will be by Professor Goel, who does not need, of course, any introduction. And he has a huge experience in all kinds of skull-based tumors with his own philosophy of how to deal with them and how to approach these tumors based on anatomical and philosophical understanding. And this gives you a complete different overview on how to tackle these problems. So let us hear from Professor Goel, and he's going to be talking on petroclival meningiomas.
Can you see my slides?
Yes, sir.
Okay. Can you hear? Voice is okay?
Yes, sir.
Okay. So, my dear and most respected Yoko Kato, needless to say that she has stimulated and taught the whole generation of neurosurgeons all over the world. Whether the neurosurgeon is from a rich country or from a poor country or from a developed country or from developing country, whether it is women in neurosurgery, whether it is men in neurosurgery, whether it is young men in neurosurgery, Yoko Kato has been the teacher of all. And such teachers of neurosurgery, there are very, very few in the history of neurosurgery. And I am very proud to be associated with Yoko for so many years. More than 35 years, I have been associated with Yoko, or more than that. And what I'm going to present to you today is my journey on petroclival meningiomas. Many of you may just know or may not know that 35 years or 40 years ago, petroclival meningiomas, nobody in the world was even operating these tumors. Skull-based surgery was born about 40 years ago, and petroclival tumors were non-surgical issues because it was difficult to even diagnose this tumor. The imaging was not so great. MRI was not there. CT scan gave you a picture here and there. So petroclival meningiomas, understanding surgery has evolved in the last 40-45 years. And I have been fortunate to see the journey of petroclival meningiomas with my own eyes. And I have enjoyed this journey of petroclival meningioma, which I want to share with you. So we know petrous bone, clivus bone, region of cavernous sinus. This area is petroclival area. Petrous apex, trigeminal nerve, medial. Here is the petroclival tumors, meningiomas. And these meningiomas extend from here to there, from everywhere. They can extend more in the clivus, more in the cavernous sinus, along the tentorium, more in the posterior fossa. So these tumors are having various kinds of extensions in dangerous depth in the center of the skull. So to approach this tumor has been traditionally difficult, and all those who are skull-based surgeons, this is the cream of tumors of skull-based surgery. But skull-based surgery or not skull-based surgery is not the issue. These are difficult tumors, dangerous tumors. Any small little cranial nerve affection, if you damage the third nerve, if you damage the fourth nerve, if you damage the fifth nerve, if you damage the sixth nerve, if you damage any perforator, you create hemiparesis, you create hemiplegia, you create unconsciousness, you create devastation. So in this area, which is in the depth of the skull, underneath the brain, is a dangerous area. And we have to avoid all dangers. We have to, at this, you cannot compromise on the exposure. You say, I do minimal invasive. You do minimal invasive or whatever invasive. You have to do a good resection and a safe resection. And I must also say that safe resection is always not possible. You can create complication and you can create bad complication. So we have to be strong, we have to be good, we have to be technically good, we have to be technologically good, and more importantly, We have to be philosophically understanding of these issues has to be perfect. So 𝒕𝒊𝒏 area, this is the trigeminal nerve, this is the cavernous sinus, this is the third nerve, here is the fourth nerve, in the depth is the sixth nerve, here in the petrous apex is the carotid artery, and these are the dural walls of the cavernous sinus. So this area, whether you come from the middle fossa, whether you come from the posterior fossa, whether you come from the nose, is in vicinity or in proximity to various dangerous issues which can create very big deficit. We can operate, we can be technically good, but small deficit, we create a bad complication for life. So these tumors can be small tumors, these can be big tumors, these can be calcified or ossified tumors. The surgical issues in all these tumors are different. Soft tumors are better to operate. Firm tumors are difficult to operate. Vascular tumor, vascularity can be different. Encasement of blood vessels. You see, this is another ossified kind of tumor, which is a dangerous tumor. Ossification and encasement. This is a dangerous combination. This is another ossification within the tumor, going in the middle fossa, going in the posterior fossa, along the tentorium. So it is a multi-compartmental tumor more often than not. My feeling is when the tumor goes in more than one compartment, it is inherently more aggressive. Here, it is going in the middle fossa, going in the cavernous sinus, going in the posterior fossa. These tumors are inherently, they are by nature more aggressive tumors. This is another tumor going in the region of sphenoid sinus, involving the cavernous sinus. See how the brainstem. So we have to be master of this dissection from the brainstem, master of dissection from the carotid, master of dissection from the basilar, from the PCOM, from the sixth nerve. So it is a ultimate, it is a high-end neurosurgery. And, when we are in neurosurgery, we cannot say we do only low-end neurosurgery. We have to do highest-end neurosurgery. And 𝒕𝒊𝒏 meningioma is one of that highest end. So it can go from one cavernous sinus to another cavernous sinus, right in the clivus. So this is another 𝒕𝒊𝒏 meningioma. So 1996, we wrote this book on skull-based tumors. I wrote with Professor Kobayashi and Professor Hongo. Both of them are very famous Japanese neurosurgeons. And we wrote this. This is the cover page of that book. If you see, there is a huge petrous bone drilling. There is carotid artery manipulation or displacement. This is the basilar artery. This is the seventh nerve which has been displaced. This is the Gassidon ganglion which has been elevated. So this kind of exposure I discussed in our book in 1996. So you can imagine in 1996 what kind of exposures we were doing. And this kind of petrous drilling was a very common part or component of my surgery. In 1996, I wrote this article, Basal Extension of Craniotomy. At that time, in 1996, about 30 years ago, the basic craniotomy was temporal craniotomy, frontal craniotomy, pterional craniotomy. So what we did extra in this article, we discussed that temporal craniotomy, we included mastoidectomy in that exposure. So this was the first time in my view that when you do basal temporal craniotomy, mastoidectomy was included in the exposure. The other thing that you see in this exposure is this is the temporal craniotomy. We removed the root of the zygoma. This root of the zygoma was removed. Roof of the external ear canal was removed. Roof of the condyle was removed. So this was additional basal exposure. So this was the direction. External ear canal is right in the line of the petrous apex. So this forms the center of the exposure. Exposure here, exposure basal. And the other thing, that beautiful thing that you see is the temporalis muscle is rotated anteriorly. Till that time, while you were doing zygomatic osteotomy, because the temporalis muscle used to come in the picture, and it took 1 centimeter of this area. So that is the reason we used to do zygomatic osteotomy. Now, this anterior displacement of temporalis muscle was another little bit of a beautiful innovation in the field. So now you see here, this is the external ear canal condyle. This is the V3, V2, and this is the petrous apex, and this beautiful basal exposure. So this was the exposure that we did during those days, 1996. This was the incision which was going back. At that time, all the incisions were coming in front. So this was going back, temporalis was going in front, and this was the basal craniotomy that I described in 1996, and we used to do quite frequently such a craniotomy. And I published in 1999 my experience with 24 cases of basal lateral subtemporal approach to pictoclaval meningioma. So you can imagine 30 years ago what I was doing. So this was my exposure. And if you have read my articles, extradural exposures to cavernous sinus tumor, we described extradural exposure to cavernous sinus tumors for the first time in the literature. Extradural approach to petrous apex. So this was intradural exposure for pictoclaval meningioma, intradural. Take a tentorial dural flap that we described in 1995. Protect the fourth nerve, go from here, do a basal craniotomy. So all these things I used to do during those days. So when the cavernous sinus was involved, petrous apex was involved, the exposure has to be from the middle fossa. So these are some cases that we did in 30 years ago. This was the tumor. You can imagine this one today, if you see, it is not such a difficult or dangerous tumor. But 30 years ago, not many people were doing this kind of work. This is 1994. Imagine 1994 means 30 years ago, this tumor, which is having encasing the carotid, encasing the carotid, encasing the carotid, encasing the PCOM. So this was quite a tumor for 30 years ago. You can imagine the microscopes were not all that good. The instruments were not good. The lighting was not good. The bipolar was not good during those days. But you see, this is the resection I did in 1994. Beautiful resection, and this person is still alive so many years later. So this was another tumor, middle fossa approach. Another one, middle fossa basal lateral subtemporal approach. Then we little bit extended the Kawasai's exposure. Kawasai's exposure was in the region of petrous apex, above the carotid artery, above the eustachian tube, above and through the GSPN. So this is the facial nerve. This is the tympanic part of the facial nerve, labyrinthine part of the facial nerve. This is the mastoid part. So what we did in 1999, this paper was published, we cut the GSPN and mobilized this tympanic and labyrinthine segments of the facial nerve, mobilized. So now the whole petrous apex was available to drill. So in my operation theater, this petrous apex drilling was a very frequently done operative technique. So this tumor, which I will not do with that kind of exposure today, but here we had mobilized the facial nerve by cutting the GSPN, then carotid artery exposure, coming from the middle fossa. So you can imagine this is also done in 1994. One custom lady who recently died of some multiple myeloma, but lived for good without any symptom for such a long time. So pictoclaval meningiomas, you have the courage to remove, and every tumor will not be firm, every tumor will not be difficult. Many of these tumors are soft and necrotic. You can easily break them, and you can easily, means it is not an easy operation. It can be potentially dangerous operation, but it is a possible operation. So this tumor also, you see, multi-compartmental within the walls of cavernous sinus, posterior fossa, different color. This was transitional meningioma. This was syncytial meningioma. So my view is tumors which involve the cavernous sinus are inherently more aggressive in nature. This was another tumor I did several years ago. You see this pictoclaval meningioma, difficult, dangerous. This is the post-operative scan. Post-operative scan looks very, very neat and clean, but I have to tell you that this patient developed hemiplegia after operation. And I am still regretting, because this guy keeps on coming to me even now. with hemiparetic gait, but now he's working and all right. But whether I should have avoided that dissection, whether I should have left some tumor behind, whether I should have not been so aggressive. So these kind of questions keep on sprouting in my mind. So at that time, skull-base surgery was evolving. This was the tumor. Somebody removed the temporal brain to expose the tumor, but did not touch the tumor. So it was quite straightforward to remove the tumor. This girl also, this is the post-operative and now quite well. So this petrous apex tumor during those times, 𝒕𝒊𝒏 meningioma, middle fossa was my preferred approach for all these cases. Posterior clinoid process, meningioma, more difficult, more anterior exposure, like a pterional exposure, coming and drilling the posterior clinoid and then removing the tumor. This is another 𝒕𝒊𝒏 𝒂𝒓 tumor coming from the middle fossa. This tumor was also one of my memorial cases I did from the middle fossa. I left some tumor behind because I could not reach from the middle fossa this, or maybe I missed this tumor. And this patient then recurred. Then I did from the posterior fossa, and this patient is now again recurred. And now I have to see what is to be done. But middle fossa to go down is a little bit difficult and little bit aggressive exposure you have to do. Many of these tumors can be vascular. Many of these tumors, but more important than vascularity is the consistency of the tumor. Soft tumors you can break. Whenever there is anostosis, big anostosis, more firmer tumor and more difficult to remove. But as we progressed, in 2004, I wrote this most beautiful paper. This tumor was removed by posterior fossa approach. Sami started removing posterior fossa by, like, he removed acoustic tumor. So Sami first suggested that some of these 𝒕𝒊𝒏 tumors in sitting surgical position can be removed by retrosigmoid operation. So for the first time in the literature, we described supracerebellar infratentorial exposure. So this supracerebellar infratentorial exposure was first described by us in 2004 on the basis of several cases. And this approach, many of you know, is now quite popular in the world. Sitting position is almost mandatory, but you can do in lateral position also. Supracerebellar, you come to the tumor very quickly in the picture, quickly attack the tumor. Many of these tumors are soft, as I have said. Learn the art of breaking the tumor, learn the art of dissecting the tumor from the adjoining structure, and you can do a beautiful job. Most important and most dangerous is the sixth nerve, and you can damage the sixth nerve if you keep on coagulating and violating the planes. You have to save not only the sixth nerve, but the other nerve, the third nerve, all these nerves. So what we described is lateral basal supracerebellar infratentorial approach. This was the most beautiful paper, and then we did. So this is the Dandy's vein that has to be coagulated early in the operation. Then you can retract the cerebellum and reach the tumor early in the operation. When the tumor is lateral petrous, of course, I will not now. I used to do all these petrosectomies and all, but now I will never recommend middle fossa to reach this tumor. There are still many people doing middle fossa approach. Here, come get to the base of the tumor, identify the cranial nerve, and then do the resection. This kind of tumor is one of the more simpler kind of tumors. Learn the art of breaking the tumor. This tumor I used to do from middle fossa and all this facial nerve mobilization. I can do this tumor in a very, very quick time by retrosigmoid, retract the cerebellum downward, attack the tumor, debulk the tumor, then break, then dissect in the subarachnoid spaces all the cranial nerves. When the tumor is more anterior, little bit more difficult. But there is no need to come from the middle fossa. Come from here, break the tumor. And I have to tell you that many of these tumors can be removed in 1 hour or less than 1 hour. If you know how to, if you learn the art of breaking the tumor, learn the art of demolishing the tumor, learn the art of breaking the tumor without much coagulation, and these are very straightforward tumors to be removed. This is another straightforward tumor where I used to do middle fossa approach earlier. More anteriorly, 𝒕𝒂𝒊𝒏 meningioma also can be beautifully removed by supracerebellar. Maybe sitting position is better. Retract the brain down. You are away from the seventh nerve. You are away from the fifth nerve. You are away from all the cranial nerves. You retract the cerebellum down. They are much easier than acoustic tumor. Remarkably easier than the facial nerve dissection. All this dissection is remarkably easier than acoustic, and you can do a very, very quick job. This is another tumor, little bit more anterior. I showed you some tumors where I did extensive pictosectomies earlier in my career, but now I will do lateral, supracerebellar, infratentorial approach, and I have to tell you that have the hang of this position, and you can have a very fascinating result. This is another 𝒕𝒂𝒊𝒏 meningioma. More anteriorly, when it goes in the cavernous sinus, these tumors are relatively soft. You can enter into the cavernous sinus from the posterior fossa. But my current feeling is that if the tumor has involved a lot of cavernous sinus, don't do much from here in sitting position, because this venous bleeding can be a little tricky and air embolism can be a possibility. So this is the tumor going in the cavernous sinus. You can follow the tumor in the cavernous sinus. These tumors are relatively soft and these tumors are relatively breakable. So it is not just the location of these tumors, it is the consistency, vascularity, relationship of these tumors with the joining structure. When the tumor goes in the middle fossa, you can come from the middle fossa, this kind of more extension if the middle fossa is also prominently there. But in many of the middle fossa tumors, when the tumor involves the cavernous sinus, you might just leave some tumor behind in the cavernous sinus. There is no need to be too aggressive with these tumors. So I do supracerebellar infratentorial approach, and this approach I am very familiar and I think many of these tumors can be removed in quick fire time and in a beautiful, when this tumor is being supplied by posterior part of cavernous sinus. These tumors, you have to get to the posterior wall of the cavernous sinus, get these feeders, and then remove. I had made prefer middle fossa approach, but this tumor was done by a posterior fossa supracerebellar approach, and this was the tumor resection. This is another tumor resection by a supracerebellar approach. When the tumor goes in the cavernous sinus, you come from here, follow from the cavernous sinus, and you can remove this. So this is a possibility when the tumor goes above the tentorium, not in the cavernous sinus, but in the tentorium, above the middle fossa. Cut the tentorium and get this tumor. Relatively straightforward. I will not recommend too much cavernous sinus handling in sitting position. When it goes in the middle fossa like that, you can remove rather safely this part of the tumor. This is another, when there is multiple tumors, these are relatively straightforward tumors to remove, and this is also this tumor. This is another quite a beautiful resection. This is multiple tumors. When tumors are multiple, this is another tumor. You see how it is going in the middle fossa, cavernous sinus. This part has been left behind. So in 𝒕𝒂𝒊𝒏 tumor surgery, it is not just resection. It has to be patient-oriented surgery. You cannot say I have resected the tumor completely and killed the person. You cannot say I have resected the tumor and I have made patient devastated. This is another tumor having big supply from the petrous, posterior petrous, anterior petrous, and wall of the cavernous sinus, and this is postoperative. This is another tumor supplied extensively from the posterior wall, and this is postoperative. So these tumors are of various kinds, various shapes and various sizes, various consistencies, various extension, how much to remove, when to leave some tumor behind, when to go for aggression, how much to remove. Now, this tumor is encasing the basilar artery, both vertebral arteries. And I just want to show you quickly some tumor. Unfortunately, I cannot show you the video, but this is the post-operative situation. This is encasing when this tumor, posterior communicating artery, is the most dangerous artery. You can damage it, and leaving behind in the vicinity of the posterior clinoid, posterior communicating artery may be a possibility. So this is another tumor. Unfortunately, my video is not running, but you can imagine that these tumors were beautifully removed, and they give you satisfaction that nothing else gives you. And of course, you have to work your life with these tumors and learn the art of breaking the tumor, learn the art of demolishing the tumor, learn the art of dissecting the tumor from adjoining structure. They may be vascular, but consistency is one thing which matters. Sometimes it goes in the clivus. You can have complications, you can have devastation, you can kill the patient, you can make hemiplegia, and all these complications I have mentioned in my articles on the subject. But you can give new life, and I have given, I've had an opportunity to operate so many tumors in my public hospital. Not always you have to remove the tumor completely. You can very safely leave some tumor behind if there is a possibility of damage to the cranial nerve, particularly sixth nerve. Here I have left quite a bit of tumor because it was dangerous. You see here this tumor encasing the artery. I have left quite a bit of tumor. Another one, I have left some tumor. It is not always necessary to, basically you have to give space. These are benign tumors. And even after this lady was in a devastating on a wheelchair, you see the smile, and significant amount of tumor is left behind in the cavernous sinus. When to do, what to do are the issues. So I know I am taking too much time, so I will like to stop. And I wish all the young people and everybody watching this webinar to understand that neurosurgery is fantastic, neurosurgery is beautiful, neurosurgery is dangerous, our life is dangerous. We should not make the life of our patients dangerous. We should operate with high degree of technical skills. We should operate with high degree of experience. We should operate and use all kinds of technology that is possible in the world. But more important is that we should see when to stop and what can harm the person and what should not be done during the operation. So thank you very much.
Thank you very much, Professor Goel. I'm Malik Sumi. You show us a lot of very difficult large petroclival meningioma cases. So, and also very thank you, Professor Shah. You introduced Professor Goel to us. So, do you have any questions from the audience to Professor Goel?
I think Dr. Kusumi, we can start with asking our discussants.
Yeah.
We have two discussants today, Professor Gharighozov and also Professor Hashimoto. Maybe they have some comments for us today. Professor Costadin, we are muted. Oh, yeah.
Thank you very much. It is really amazing to listen to Professor Goel about his extensive experience. It's unique, I will say, definitely, and that was extremely valuable for junior neurosurgeons, because particularly this pathology is learned from the master. I mean, we cannot apply standard approaches and standard techniques according to specific characteristics. Always a formidable task to remove such kind of tumor completely. And it was very important from my point of view that Professor Goel focused on when we have to stop, because this is a really, really very difficult point when such kind of surgery is done. I would like maybe just to, if appropriate, to ask just a few details about are practically all petroclival meningiomas currently in your domain approached by the supracerebellar route, or you might be considering, let us say, super and infantile combined approaches to the area? My second point is, what is your opinion in general about stereotactic radiosurgery as a follow-up in some kind of adjuvant treatment for this kind of lesions? And finally, for our endovascular specialist, is there any point in looking for preoperative embolization so your work is really done maybe a little bit easier? So sorry for the many questions.
Let me answer your question. Number one, see, there are several petroclival tumors that have quite a bit of middle fossa extension, like cavernous sinus, supratentorial. And no matter what, to remove these tumors from a posterior fossa approach is not always easy. It can be dangerous by, to go above the tentorium and dissect from below is not easy. So in those cases, of course, there I will say today, if I have 100 petroclival meningiomas, at least 40 petroclival meningiomas will be by middle fossa approach, or 35 or 40. So there is a lot middle fossa approach, transpetros approach has been as I mentioned to you, it has been a part and parcel of my life. Petrous temporal dissection, drilling. I have done several cadaveric temporal bone workshops in Japan. Yoko Kato may know about it, and you also may know about it. That I used to do several cadaveric temporal bone dissection. I used to drill the facial nerve in Shinshu University. I did in Tokyo University. I did in Osaka University. Many temporal bone dissections where we used to show the how to drill, what to drill. During 30 years ago, this drill was an ENT instrument. Not many neurosurgeons knew about this drilling. So we used to, Midas Rex courses were very common at that time, and though they used to bring their drills, and we used to show how to drill and what to drill. And so drilling was a very important component of our life. And I used to do drilling transpetros approaches all the time. But as I mature more and more and more, I have a feeling that many of these tumors do not need too much exposure. Many of these tumors they are relatively soft. They can be easily dissected. They can be which tumors are going to be soft, which tumors are going to be firm, which tumors need more exposure, which tumors can be removed by a small exposure, has to be learned and acquired and evolved. That is the evolving experience in this business. This petroclival is the highest end of neurosurgery, and we have to incorporate all our experience to do and select a best and beautiful approach. I cannot be fascinated with one approach and do that approach for all the cases. That is the answer. Second thing is about radiation, SRS and all radiation after if I have left some small residue, whether I need to give radiation. You see, most of these tumors, when they are multi-compartmental, are more aggressive than convexity meningioma, or more aggressive than a single compartment tumor. When they involve the cavernous sinus, they are inherently more aggressive. So when they involve the cavernous sinus, go inside the vicinity of cavernous sinus, SRS may be an option. But if it has not gone inside the cavernous sinus, it is just outside where you have left because the tumor was difficult to dissect from the cranial nerve. It is intracranial, middle fossa and posterior fossa. That is a good case for observation. There is no need to hurry for radiation, and you can easily, if the tumor is going in the sphenoid sinus, for instance, you have to 100% give radiation after the surgery. If it is going inside the cavernous sinus, you have to consider radiation. But if it is not going, if it is a clean tumor, you have left some tumor only because of difficulties in surgery, that is a good case for observation without radiation. And I don't like embolization for any tumor, except for two situations. One is glomus jugular tumor, where I like to do preoperative embolization. And I will completely not recommend radiation embolization for nasopharyngeal angiofibroma. I have reported 2 cases of nasopharyngeal angiofibroma where preoperative embolization was done to reduce the vascularity and the person developed complete blindness. So 2 cases in my own city. I will never do embolization now for nasopharyngeal. For meningiomas, of course, I don't do.
Thank you, Professor.
Thank you.
So, are you okay? So we will move to the next question. Do you have another question, or we move to the Dr. Ben? Do you have question, right? Please start.
Yes, and thank you, Professor Go, for your excellent lecture and also your lifelong contribution to this surgical approach to the petrocalcium meningioma. It's fascinating to see the anatomy and your dissections and those difficult cases. And I'm also working on scalp-based surgery. I would like to ask about your view about the futures for this disease. So, you know, with many experts like you and also other Japanese doctors, so extensive scalp-based approach are modified into like a more minimally invasive, and also with the advances of the technology like endoscope, so things are getting more minimally invasive. So what is your view on the future for the surgical approach on petrocalcium meningiomas? Thank you so much.
That is a very fantastic question. I enjoyed this question from you. Very beautiful question. See, one thing I can tell you. Petrocalcium meningioma surgery is a difficult surgery. Petrocalcium meningioma surgery can be associated with dangerous complications. You cannot, reduce your exposure or make it minimal invasive and struggle to get to the tumor. If you are comfortable in small exposure, very comfortable, you can do it. But what you need is more comfort, maximum comfort. Surgeon should be completely comfortable. He should not be struggling with the exposure a little bit long. For this, in this perspective, I will say endoscope is, of course, very rapidly evolving and very many fantastic surgeries being done by endoscope. But I have a feeling for petrocalcium meningioma. Means you are operating with an endoscope from a distance and then having difficulty in coagulation and all. Of course, you can show a beautiful picture and all those things. See, these things will evolve, but for petrocalcium meningioma, it is the technique which is important, technique, more than technology. It is the exposure that is important, more than minimization of your exposure. I'm not saying you open the whole head and all, like we used to do. I showed that I used to do facial nerve mobilization, carotid artery mobilization, whole pictures, cochlear, transcochlear approach, this approach, all these things we were doing, but I don't need that now. So what is required is good experience. More and more cases you should operate. More and more handling of the tumor you should know. And if you have a big, good exposure, you can use the endoscope and all those things. But if you come for these tumors from the nose and start doing endoscope from the nose for petrocalcium meningioma, I don't recommend. If you ask me, I don't recommend. But there are some people who are becoming good in this and they might just be able to do. But I don't think I will recommend, and I don't agree with that concept. I think you have a beautiful exposure, beautiful technique. Work with two hands and close to the tumor. Close to the tumor you go. With endoscope, you are a little bit away from the tumor. You may have side views, but you have a distant view. So go close to the tumor, dissect. Learn the art of breaking the tumor. And I think this is my view on this.
Thank you so much. Excellent. Thank you so much.
Thank you, Professor Goel. I have one question. You told us you cut the superior petrosal vein when you are doing a supracerebral infratentorial approach. Do you have any experience of venous congestion caused by superior petrosal vein? You don't have?
This is a very important question. You see, when you are doing supracerebral approach to petrocalcium meningioma or anything, unless you cut this vein, you cannot retract the cerebellum down. See, you cut the vein, then you can retract the cerebellum down, very much down, and then you can have so you have to cut this vein very early in the operation. Of course, you can have a complication. Of course, you can have some, and many people have reported when they do trigeminal neuralgia and they cut the nerve, cut the petrosal Dandy's vein. There can be, and I must say that I have also suffered during trigeminal neuralgia surgery, one patient of venous infarct. So there is a problem, but many people who do this vein sectioning on a regular basis, including Peter Janetta. Peter Janetta used to recommend immediately cut the vein and then do the dissection. So many people of that level have shown that nothing, the dangers are very minimum and that can be done. But of course, this is one question which will have to be answered with, this is a very relevant question.
Thank you. So, any other question from audience? It's all done. Okay. Thank you, Professor Goel. We are going to the next speaker. Thank you very much. It's a so educative lectures. So we are moved to the Dr. Monal Patil. She is now fellow of the Fujita Hospital under Professor Yoko Kato. She's talking about a technical case series of distal radial artery approach to web treatment of aneurysm. Please start your lecture.
Yeah, good evening, everyone.
Thank you.
I'll share my screen. Is my screen visible?
Yes, it is.
Yes,
Yes.
yes.
Yes. Good evening, everyone. I'm presenting this topic on a technical case series of distal radial artery approach to the web treatment of aneurysms, which is my research topic at the Fujita. I have no disclosures. So neuroendovascular procedures have been traditionally performed using the transfemoral approach. The transradial approach in recent years have gained popularity. The transradial approach was introduced in 1989 in cardiology practices, large interventional cardiology studies, and later neurointerventional studies have shown clear benefits of the transradial artery over the transfemoral artery in terms of fewer access site complications, shorter observation period, faster recovery times, higher patient satisfaction, and reduced cost. But transradial artery has its own disadvantages, like the radial artery occlusion and hematoma, which has led to the innovation of the distal radial artery approach, which has the same benefits as the proximal radial artery approach, and additional advantages such as shorter hemostasis times, fewer ischemic events, slightly higher patient satisfaction, and preservation of the proximal radial artery for future neurointervention. The DRA involves puncturing the radial artery in the anatomical snuff box. It's a triangular space which is bordered by the tendons of the extensor pollicis brevis, the abductor pollicis longus laterally, and extensor pollicis longus medially. The scaphoid and the trapezium bones form the snuff box floor. The radial artery bifurcates with the superficial palmar branch forming an anastomotic arch with the ulnar artery. Therefore, even distal occlusion rarely cause ischemia at this point. The studies done by Kuhn et al. And Hoffman et al. Have established the safety and efficacy of the distal radial artery over the transradial approach for numerous neurointerventional procedures. The radial artery occlusion rates are same for the radial and the distal radial according to the disco-radial trial, but many institutional studies have shown decreased incidence of the radial artery occlusion in the distal radial artery approach. The web device is a nitinol braided wire structure which is designed to disrupt the blood flow at the aneurysmal neck. Clinical trials in Europe and United States have led to the FDA approval in 2018, and since then its use has become widespread. Now, studies like the 𝑨𝒕𝒊𝒏 have established good short, mid, and long-term clinical outcome of the web deployment of the aneurysms. So, combining distal radial artery access with a web device presents an optimal strategy to the endovascular aneurysm treatment, enhancing the patient's safety and comfort. And it is supported by studies which have followed the web deployment via the distal radial artery without any complications. The introduction of the transradial artery since 1989 was a starting point for an evolution of transradial technologies with dedicated needles, hydrophilic sheaths, catheters, and hemostatic devices, followed by continuous improvements in the profile of the intravascular devices in the cardiac intervention. So far in the neurointerventional experience, the most common guide catheters used are the same 6F devices used for the transfemoral axis. The wrist guide catheter is the first device specifically designed for the radial approach neurointervention. The wrist system, the guide and the select catheter, was approved by the US FDA for the radial artery introduction recently. The wrist was studied in these two papers. A multi-center study studied the wrist radial access system in 10 patients, the web deployment, but the Vakas et al. Studied the wrist catheters in all the neurointerventional procedures except for the web. But they have shown the wrist catheter systems has a high success rate in all these procedures. In this study, we share our experience with the aneurysm treatment using the web device via the distal radial artery axis, employing the triaxial catheter systems with a focus on the guide catheters and the intermediate catheters. This is a retrospective and observational study conducted over a period of 3 months. All the patients in this study received a dual antiplatelet medication before the intervention, and all procedures were performed under general anesthesia. If the radial artery was palpable, the right distal radial artery was chosen as the primary puncture site, and all the cases were performed by 3 experienced neurosurgeons with experience in utilizing the distal radial approach. The forearm is kept partially pronated in a thumbs up position, and the puncture is always made under ultrasound guidance for the better visualization of the radial artery and the puncture needle. This is the catheter system. The wrist radial access device consists of a 5 French radial access selective catheter and a wrist guide catheter, which comes in different lengths and which is guided through a 7 French hydrophilic glide sheath cylinder. And this is the preparation which is done before the start of the procedure. Intermediate catheters used was Vecta 46, which is a small diameter, low profile catheter. VI 21 or 27 was a delivery micro catheter used, and Synchro Select was the micro guide wire used. The woven endobridge web device SL and SLS was used as per the size chart, which is the pre-operative planning and also intraoperative planning. The procedure was defined as successful if the intervention was successfully performed by the distal radial artery approach. This is the ultrasound radial artery. This is a puncture done. After the puncture, the Terumo guide wire is advanced to the needle, followed by the 4 French short sheath, and nitroglycerin is administered. This is a short video showing the web deployment. This is a saccular aneurysm at the basilar trunk. The maximum diameter was 8 millimeters and the dome neck ratio was less than 2. A web SL size of 8x4 was selected, and this is a triaxial catheter system which was chosen. The proximal and the distal radial artery markings were done, and under ultrasound guidance, the puncture was made, followed by the guide wire insertion, the 4 French, and followed by the 7 French glide sheath insertion, and the radial artery runs were taken. At this stage, heparin is administered, 5,000 international unit. The 5 French inner catheter is telescoped inside the 7 French wrist guide and advanced together over a radio focus, half-stiff guide wire into the right vertebral artery, and right vertebral artery runs are seen here, showing the aneurysm at the basilar trunk. Following this, the wrist guide catheter is advanced into the right vertebral artery. The basilar cranial runs demonstrate the aneurysm. The 3D angiogram demonstrates the anatomy with the dome projecting superiorly and posteriorly. After the deployment of the wrist, the vector is deployed further distally into the basilar artery, and the VIA is guided over the synchro. This is a VI microcatheter which is parked at the center of the neck of the aneurysm and the dome. The 𝑬𝒏𝒆𝒊 8x4 device is deployed as seen here. Now combine unsheathing and pushing out with location centered at the dome to open the device in the form of flower shape. A gentle push at this stage allows the web device to balloon up. The microcatheter is then retrieved, and this is the proper positioning of the device at the neck of the aneurysm, after which the left vertebral artery runs. Confirm the proper configuration of the web device and the flow stagnation of the aneurysm. After completion, the radial sheath is removed and hemostasis is achieved with a bleed-safe compression device. Now, we had total 17 patients, with the females comprising the maximum about 76%, with a mean age of 72 years and neck width of 4.26. The majority of the aneurysms were in the anterior circulation, the anterior communicating being the most common. There was just one ruptured aneurysm. The approach was taken from the right distal radial artery in 16 patients, and one was from the left distal radial artery. It was a basilar top aneurysm case with a narrow right vertebral artery. So the target vessel was chosen, the left vertebral artery. The average puncture time in this series was the mean 76.18 minutes and the median 70 minutes. The target vessel was right side in 7 patients and left in 10, and the crossover was 2, with a crossover rate of 11%. There were no major or minor complications in this case series, and the procedure success was 88%. The type of aortic arches was studied in all the patients. The guiding catheter wrist was used in almost all cases except the crossover cases, and where adjunctive devices were used. The most common intermediate catheter was Vecta 46, followed by Sophia Select and Guidepost. And Fubuki catheters and Sophia Select was used in 3 cases instead of the wrist devices. Now, talking of the advantages of the distal radial artery, the combination of minimal invasive access with a web device, which does not require dual antiplatelet therapy, optimally reduces the bleeding risk. Ultrasound guidance improves the success rates with limited repeat punctures. This approach allows the wrist movement post-procedure, and it also preserves the proximal radial artery for future interventions. Based on the clear safety benefits and increased patient satisfaction, the hospital has adopted a distal radial first approach for most cases. If it is not successful in the first few attempts, then conventional radial artery is chosen. In the first case of the crossover, which was an anterior communicating aneurysm with the dominant left A1, we found that the patient had a type 3 aortic arch, and the anatomical factors thought contributing to the crossover was a narrow angle between the innominate artery and the left CCA. In crossover 2, which was also a case of anterior communicating aneurysm, the angulation of the right subclavian artery was very acute and it was twisted S-shaped. So the crossover cases involve the left side internal carotid artery as a target vessel in both the cases. The successful navigation of left ICA via the right transradial artery is largely influenced by the specific vascular anatomy of the aortic arches and its branches. As the aortic arch transitions from type 1 to type 3, it becomes more perpendicular and results in parallel alignment between the innominate and the left CCA, reducing the takeoff angle of the left CCA. The sharp curve at the entry point to the left common carotid artery results in inadequate placement of the guiding catheter and diminished proximal support, which causes the catheter to fall back into the aorta. The angulation of the right subclavian artery reduces the torqueability and the trackability of catheter, which interferes with the navigation and manipulation of the catheter. So in some instances, a left distal radial artery approach may serve as a viable alternative. The benefits of intermediate catheters are multifaceted because it allows positioning just proximal to the aneurysm. It enhances the stability and control of microcatheters and provides the support strength for the web device deployment. Now, the wrist, vector, and the VI, the triaxial system, is used in most of the aneurysm web embolization procedures. But the wrist guiding catheter does not support a 6 French intermediate catheter like the SOFIA Select, and it is a small diameter 4 French vector 46, the intermediate catheter, which can accommodate just one microcatheter. So when planning adjunctive coil and stent placement, a balloon dilatation is required via the coaxial web deployment. 8 French guiding catheter like the Fubuki and 6 French intermediate catheter such as SOFIA Select is used. SOFIA Select is a larger diameter intermediate catheter which can accommodate 2 microcatheters. So this study contributes to the expanding body of literature investigating the use of new devices in aneurysm management. Wrist guiding catheters and the low profile intermediate catheters, they are feasible and they're safe in the web deployment. The distal radial artery has a higher rate of procedural success and a lower complication rate. So it's a feasible approach for neurointervention. I would like to thank Professor Yoko Kato for giving me this opportunity to present at this webinar. I would also like to thank Professor Nakahara, Dr. Tanabe, Dr. Haraguchi, Dr. Hasbe, and the entire endovascular department, Fujita Hospital, for helping me learn the neuro intervention here. Thank you.
Thank you very much, Dr. Patel. You show us a very new technique. So let's start to discuss from audience. Do you have any question from audience? Please, Aya. Let's start.
Thank you for your lecture. I have one question. My hospital, we do only web placement for bifurcation type aneurysm, for example, basilar aneurysm and MCA bifurcation aneurysm. But you do ICPCA and IC anchored, so you do sidewall type. So is it difficult to place it web on the sidewall type?
So here, most of the aneurysms were the ACOM aneurysms, the M1, M2 bifurcation aneurysms. I've seen the basilar top. The sidewall aneurysms is the basilar trunk that I've shown. The advantage of the triaxial system is that it can be used, I think, in the sidewall aneurysms as well. Because the wrist guiding catheter, the vector, and the VI makes it possible for the proximal support for the proper web deployment. So I think it is the triaxial system that makes it possible for the successful deployment even in sidewall aneurysm. I think it clears the question.
It's okay.
It's okay. Thank you.
Okay.
Thank you.
How about another question? So how about other audience? Oh, I'm not familiar about the endovascular treatment, but you show us a 70 case from the radial artery. So you show 2 or 3 cases failure case. What the cause of the failure to procedure by radial artery? You show a successful case is maybe 15 cases successful.
Yes, 15 cases. Yes.
Successful, but the other 2 case is failure. What cause
Yes.
is it?
Yes. Out of the total 17 cases, all were the initial approach was the distal radial artery approach, but in 2 cases, during the deployment of the wrist catheter, which is a guide catheter, it was not stable in the target vessel, and the guide catheter used to fall into the aorta. So, and this we found out that the 2 cases had a different arch anomaly, the aortic arch anomaly, due to which the crossover had to be done to the right transfemoral route approach. The transfemoral route, yes. Yes. So, in literature, the crossover usually the crossover cases, the main reason is the anatomical variation, such as in the aortic arch, as I have shown in the slides. That is the type 2 and the type 3 aortic arch. They have the ascending aorta, which is perpendicular to the descending aorta, and it becomes difficult to navigate through the acute angle. So due to which there is not much proximal support for the guiding catheters. And when you do a transfemoral approach in these cases, you approach via the descending aorta, and then you can navigate the catheters easily because it's a better angle, an obtuse angle. And in these cases, 2 cases, that's why after going through the descending aorta, the web deployment could take place successfully. So basically, preoperative planning should be done in which the aortic arch, any abnormal variation, the angle between the brachiocephalic and the common carotid artery should be seen. Because in most cases where the target vessel is in the left ICA, the left CCA, the right radial approach may not be good. So in that case, you can take a left distal radial artery approach.
Okay, thank you. So how about other question from audience? It's all done.
Maybe just a short.
Oh, okay. Please, Dr. Ǩalagiozov, please start your
The
question.
smallest diameter of radial you use.
Sorry, sir, I didn't get you. Can you repeat the question?
What is the smallest diameter of the distal radial that you use for the procedure?
Okay,
What is the margin?
Yes. The glide sheet or the guide that we put, that is 6 French, but the 4 French sheets are the minimal diameter that we use. Yes, the 4 French, 5 French, and 6 French. 4 French is the minimal.
It's about 2 millimeters. 2 millimeters. About 2
yes,
millimeters.
The radial artery is 2 millimeters. Yes, but the radial artery has elastic properties. You can use the 8 French sheathless guide catheters also, such as the Fubuki, which is large. Yes.
Thank you very much. Thank you. Thank you. So let's move to the, thank you, Dr. Patel. So we move to the next speaker. Next speaker is Professor Minjin Bird-Hojayev. He's Vice Chairman of Presidential Hospital, Austin, Kazakhstan. So his lecture title is Brain, AVM, and Vascular Treatment. Please start your lecture.
Hello, dear colleagues. Thank you so much, Professor Yoko Kato, for the kind invitation. For me, it's a great opportunity to talk on neurosurgical webinar. And mostly last 10 years, I'm all the time presenting my experience on neuroradiological courses, but today it's the first time with neurosurgeons on international area. And the Japanese auditorium is very specific, and you have very experienced microsurgery, but I will try to talk on endovascular. Okay, I hope you can see my screen. Okay, I hope you can see.
Yes.
Yes.
The title is a little bit different. Brain AVM, where is the limit for endovascular? It would be some mixing from other cases, not about only limits. There is also the opportunities. And this is my disclosures. And before the AVM, it was a great talk from Professor Goel. We participated in several meetings together, but I know him only online. I hope one day I will meet him offline and will shake his hands. And this is a case of clival meningioma. The treatment done in 2022, 62 years old female came from west part of Kazakhstan, and it was a time of strikes in Almaty, and we did the treatment, and we planned to observe her, and it was a supply from ascending pharyngeal, and it was supply from one of the branch of ascending pharyngeal to the posterior fossa. And this is angiography, and the image below on the right side, you can see the super selective angiography from the sonic microcatheter. In this case, we used ascending pharyngeal, and on the image on the top, on the left side, you can see there is a branch going transosseal to the meningioma. And we have a Kazakh modification of pressure cooker technique. We placed second microcatheter, which was headway duo, and we coiled proximal part of detachable tip of the sonic, and it allowed us to push the liquid embolic to the meningioma. And if you notice, there is some branch on the top right side coming from the Bernasconi casinari, from the ICA on the right side. And it's a little bit risky when you deal with this region. There is a lot of anastomosis, and you need to keep in mind about this anastomosis. And thanks to visibility of the 𝑧12 and the Philips angio suite, we can control. And after total embolization, we suggested to patient, it's possible to observe this meningioma, but the mass effect after embolization usually increase a little bit, and patient said, okay, I have headaches and I don't want to observe. Let's resect the meningioma. We observed for 2 weeks, and after 2 weeks, my colleague Sarshayev Marat, he is now a chief of the department, resected this meningioma. And from the neurosurgical point of view, after embolization, this meningioma became like a toothpaste. It's quite soft, and when you suck it with aspiration catheter or with the suction, and it became easy. And for the neurosurgeon, this situation is most comfort situation. It's not bleeding. Your matrix from the dura is closed, and it's controllable situation. And resection of this meningioma, I think, really enjoyable, and patient discharged without any neurological deficit, without any complication. Yes, let's talk on AVM. It was just a few words about the place of endovascular treatment in meningioma. And in Kazakhstan, we have more than 300 cases with embolization, and 25% of this meningioma is disappearing, is resolving, and 25% of meningioma became stable, and we are following them. Our experience in National Hospital is a central clinical hospital in Almaty. In last nearly 9 years, we treated 260 patients and 484 procedures done. Because of AVMs was big and needed several sessions, and mostly in this group, males, 3% more. And we are treating mostly adults because we have no pediatric department in our hospital, and mean age is 36, quite young patients. And this is a profile of the patients. More than half of the patients had a ruptured AVMs. 12% of the patients was hospitalized at the acute period of bleeding, and in elective cases, most of the MRS was 1, and at the time of discharge was not changed. You can see the most symptoms in unruptured AVMs was seizures, nearly 58%, and more than 73% in ruptured AVM was headaches. Location of the AVMs was 89% hemispheric. I think for the microsurgery is the same, and the cerebral AVMs in 9%, and 2% was brainstem AVMs. Spitzer-Martin grading scale, and most of the AVMs was grade 3 and grade 4. Complete obliteration after embolization only in 42%, and stable occlusion in 39% of the cases. 17 patients was underwent for surgical removal, staged endovascular treatment, 248 patients, and 6 patients sent for the radiosurgery with gamma knife. Embolic agents, we are combining all kind of embolic agents, including glue and all type of EVO-based liquid embolics. And we started to mix with the coiling, the proximal or distal part of the afferent vessel. I will show some examples. And about complication, we've had MRS 6 in 4 patients. It's less than 1%. And all total complications is 63. It's nearly 14%. We count all kind of complication, including minor neurological deficit, ischemia, seizures, and temporary neurological deficits. And I want to talk a little bit about my YouTube channel. And nowadays we are transmitting all cases online. And this week, fortunately for me, but unfortunately for my auditorium, we didn't have cases, and I especially prepared for this meeting. And if you go for my YouTube channel, there is a lot of live cases. It was recorded specially, and the explanation of the cases during the case in English. It's very comfortable for the international colleagues. I stopped to explain in Russian language. I'm pushing my colleagues to learn English. And limits. The first limit was Aruba trial, which stopped the treatment of unruptured AVMs, but follow-up of these patients showed that the cumulative effect of the unruptured AVMs in follow-up increasing the bleeding rate. That's why these patients should be controlled more closely. And in some cases, maybe this patient need treatment, unruptured AVM cases. And this is unruptured AVM, 26 years old female. She planned to give birth, but neurological colleagues said, no pregnancy, you have brain AVM, it's risky, you will die. And then we scheduled for one session treatment. We call this technique field first technique. We're injecting field, and we are continuing with other type of liquid embolics based on tantalum. And this is after embolization, complete exclusion, and patient planned the pregnancy, and I hope the family is quite happy. In Kazakhstan, it's very important to give birth at early ages. And this is a follow-up. Patients sent me this follow-up MR just today. She had seizures and headaches, and after 2 sessions of embolization, it's a control MR in nearly 1 year, and AVM is completely excluded, and we are planning DSA angiography in 1 year after embolization. It's our standard protocol. This is a young boy, 7 years old. He had a bleeding. It was parenchymal bleeding, and the patient was in Tashkent in emergency hospital. And my colleagues asked to treat this patient. It was one session treatment, combination of Onyx 18, 20, and 34, one after one, and it's just one session, and AVM was completely excluded. And about the limits, once we accept our limits, we go beyond them. It's very important, and our thoughts and imaginations are the only real limits to our possibilities. The pressure cooker technique, it's one of the techniques helps us to break the limits. And Professor René Chapeau with SN team evaluated and put this technique on the practice. And I was happy. I learned this technique in 2012. And in 2013, this 11 years old boy came to National Neurosurgical Center. I used to work there, and this AVM at that time was untreatable AVM. It was first attempt, and one of the branches from Hübner artery was occluded without penetration of the AVM. And if you notice, this patient has no straight sinus, and most of the drainage to the collateral, venous collaterals, from the 𝒊𝒏 vein and the Rosenthal veins. And we placed 3 microcatheters in 11 years old boy. It was a balloon. It was 2 Apollo 1.5 centimeter, and we start inject Onyx 18, and then put small drop of glue at the detachable point of first microcatheter. And this is control result. AVM was completely occluded with this final cast, and patient had no additional neurological deficit at the time of treatment. And today, this boy is 22 years old. And this is explanation how he's doing. Placing 2 microcatheters, coils, then NBCA, and then injection of the. It's a classical pressure cooker technique. And in our modification, we are placing 2 microcatheters, both detachable, and then concentrated NBCA, nearly 70%. And we start inject liquid embolic tantalum-based Onyx or squid. And after that, after short reflux, injected NBCA concentrated and followed the injection. This treatment done in 2017 during the Neradi course in Almaty. We treated this locant area AVM on left frontal lobe, and it was single session operation with complete exclusion of the AVM. and it was DSA. After 8 months, AVM was completely excluded. Unfortunately, from 2019, NVCA not available in our country, and we start to use fill in combination of fill first technique. Yes, it's also on my YouTube channel, and this is 𝒕𝒊𝒏 grade 2 or 3 AVM, and we did a 2-session treatment. The first session in April 2019, partial embolization, and then second session we catheterized with 3 microcatheters, all feeders, but injected liquid embolics only from 1 microcatheter. And with other 2 microcatheters, we did a super selective control. And in second session, we completely occluded the AVM, and patient was discharged without any additional neurological symptoms. Total time of injection is 45 minutes. Yes, the limit could be catheterization problem. This is a angular zone AVM on the left side. We started occlusion of the AVM, but it was small feeder from the lenticular straightening artery. We tried several times to go to the lenticular straightening artery, but it was impossible. And during the catheterization of the artery, some part of the AVM is bleeded. The vessel was so tiny and it was fractured. We excluded the bleeding part, and then this is the remaining part. And I asked my colleague Marat to resect this AVM. It was small bleeding, and this is after resection. AVM was resected with the remaining part, and patient was neurologically intact and discharged. This is a control angio after resection. AVM is excluded, and brain looks quite normal. Callosal AVMs, yes, several attempts. This is after second session, and we asked our gamma knife colleagues to take this patient for the gamma knife, but they said it's exclusively one draining vein, and after gamma knife, the vein could be occluded and AVM might rupture. We explained to the patient, and patient agreed to have an endovascular treatment. She's young and she planned the pregnancy also. And we went super selectively from the and passage feeders from the pericallosal artery. It was at the same session transvenous approach, and that then small feeder from the ACOM segment. It's looked like one of the Hübner branches. We couldn't reach this artery, and it was bleeding intraop. It was ventricular bleeding, and I asked my colleagues, Afzal and Marat Sarshaev, and they took the patient for the clipping. They did a cisternostomy with the membran Liljeqvist perforation, and at the same time, they found the small afferent coming from the ACOM segment and just put the one clip without AVM resection. And after microsurgery, there is no remaining part, and the AVM is completely excluded. The control angio was in September, and today patient is pregnant and planning to give birth in next 5 months. This is after surgery. And this is another case, small remaining part, and it was unreachable, and we followed this patient, and we tried to exclude and went to this part and finally occluded this AVM without bleeding. Recent case, last this week we had a patient 70 years old. On right temporal artery, there is AVM, Spodź-Martin 1 with the M-passage feeders. There is a distal part of the temporal branch, and we did a technique. We placed coils distally. It was dense packing of the coils. Then we placed sonic microcatheter in between and coiled the proximal part of the detachable tip of the sonic, and injected liquid embolic with complete exclusion. And you can see from the vertebro-basilar system, there is a retrograde flow of this branch, and patient had any neurological deficit after treatment. He had a headache before the treatment, and we will follow and we'll see how the headaches will change in the future. Eloquent of adjacent brain is also the limit, and in endovascular treatment, yes, we have high chance of additional neurological increasing of the symptoms. It's frontal lobe AVM. We did treatment several times, and I have only intermediate angio from the treatment. But finally, he was a young medical student. After several sessions, we completely endovascularly excluded this AVM from the circulation. But at the end, he has slight motor sensoric aphasia. He can talk, he can understand, and there is a hemiparesis on the right side at the end. Other case, the same eloquent area, the first session of the embolization. And other case, young patient, I started to treat him in Astana 10 years ago, and he came to Astana again when I changed my working place for the presidential system. And we did additional 2 sessions and completely excluded this AVM from the circulation. And now he's free from the seizures. The main symptom was seizures, and now seizures stopped, and he married, and he has family, and he's happy. Monoplane system is also the limit, could be. This is deep located basal ganglia AVM. We did combined approach from artery and venous system. It was bleeding time, and it was edema around the AVM, and we went from this stenotic deep draining vein, and we placed this microcatheter in vein and other microcatheters in artery, and balloon for the assistance from arterial side to navigate the microcatheter and assist if there is a bleeding. But final cast, it's like a sculpture of the AVM, and there is no more AVM, and AVM excluded from the system. Emergency embolization, it's not the limit. This patient came from emergency hospital. From the first step, we placed ventricular drainages and closed them. It was 2 days after hemorrhage, and patient came in comatose status. Because of the brain clear, we decided to take this patient, and it was 45 minutes embolization in 4 hands. Together with my colleagues, we injected in 40 minutes and completely excluded this AVM from the circulation. And patient recovered, and now he can walk, he can talk, he can work. This is follow-up angiography, and AVM is excluded from the circulation. Other young lady with the AVM and aneurysm on the feeder. We placed 2 sonic microcatheters. We used field first technique and injected squid 18 after field. And we completely excluded this AVM from the circulation. This is a schematic drawing of the treatment. Yes, after complete exclusion without microsurgical evacuation of the hematoma. It was just headaches, and we observed the patient, and usually in a couple of months, hematoma is resolving. This is a treatment of colossal AVM. It's available on my YouTube channel. You can go for the 22nd of September. I will do quickly. It was 3 feeders. In first session, we injected Aptura. It's a new liquid embolic from Spain, and it's disappearing after 45-50 days. And this cast was after first treatment from the left pericallosal. Control angio in 1.5 months. From the left side, AVM is not more visible. And you can see on the top, the cast of Aptura is nearly disappeared, and it's quite amazing. And the remaining part from the PCA and the right pericallosal territory. And we went from the right pericallosal and excluded the part from right pericallosal. And also we took some part from the PCA territory during the embolization from the pericallosal artery. And you can compare on the top, it's before the second session, and below, it's a cast of onyx. It's a remaining part of the AVM after the second session. You may compare the cast of street 12, as it's took part from PCA also. And we are planning this patient for February for the third session for 𝒚 And from the complications, yes, venous infarcts, bleeding is also the limit. This is a basal ganglia AVM with the aneurysms on the lenticular striating artery. We did 1 session embolization with complete exclusion of the AVM. But unfortunately, on day 5, it's a usually time of venous thrombosis, and patient had a headache, hypertension, and became comatose. We did the hematoma evacuation, the compressive craniectomy, but unfortunately, patient died. And before the questions, yes, we are doing International Neuroaddict Forum nearly every 2 years in Kazakhstan. The first 3 was in Almaty, and the last one was in Astana. And every year we are doing English-speaking courses, discussional course in Almaty, and we are inviting you for the next of the courses in Almaty or in Astana. And you can speak in English, in Russian, in any languages. We have translators. And if you have any questions, you can send to my email or WhatsApp number. And thank you for your attention.
Thank you. Thank you, Professor 𝒊𝒏. Oh, thank you, Professor 𝒊𝒏
Professor Manzo.
Wendell, thank you. So you are showing us many AVM treatment case. So please, from audience, please start your question and comments. Please, Aya, please start your question.
Thank you for your presentation. In Japan, NBCA was officially approved for intracranial disease this year. In your surgical strategies, you use different embolic materials, so depending on the situation. Since NBCA became unable in your country, has your treatment strategies changed?
It's a little bit changed, but not in all cases. And thanks to transvenous approach in complex feeders, we can go transvenously, and we can occlude the complex part of the AVM from the venous approach. And yes, this kind of patients who needs the NBCA is less and less. And thanks to coils, we are placing at the detachable point of microcatheter densely 3-4 coils. It's electrically detachable, and we are waiting from 5 to 10 minutes. At this time, the coils producing thrombus, and the part of the coiled segment is thrombosing and creating very good plaque, and we can do pressure cooking without NBCA injection. Yeah.
Thank you.
Thank you, Professor. How about another question?
Professor
Can I
Goel.
ask?
Go ahead,
Can I ask?
please.
Yeah. So that was very, very fascinating, very fantastic lecture on endovascular treatment for AV arteriovenous malformation. I think I have never seen so many AVMs being treated so nicely by endovascular treatment. My feeling still is, you see, if the best treatment, which anyone will agree that if you can remove the AVM by surgery, if you can dissect, if you have the power, if you have the experience, if you know how to remove the AVM by surgery, there is no treatment better than that. Of course, when surgery is not possible, I will say embolization may just be the option, and then radiation may be the option. I want to ask you one question. If you think the surgery is safe and possible, would you like to do surgery, or would you still like to do embolization? And if you have a surgeon who says, I can remove it and I can safely remove it, do you think you will opt for embolization, or you will say, okay, give radiation, do surgery? What is your opinion?
It's a nice question, Professor Goel. And I know you're a very experienced microsurgeon, but the life is life. And for the microsurgeon, it's important to go home as early as possible. And AVM 4-5 centimeter, it's a one-day treatment. And for me, it's better to prepare this AVM if it's possible. As much as possible, I can shrink the AVM, and if there is a remaining part, then my neurosurgeon is happy. The removal of embolized AVM like a cavernoma surgery. And I think it's far more better when you have control of the bleeding from the beginning of the artery going to the AVM. And I think we have very good collaboration. And at the time we needed microsurgery, we can ask our colleague to go and resect. But I had one very nice comment today from the relatives of my patient. And patient 76 years old, scared from the surgery. He came to us and we did the endovascular treatment under local anesthesia. And he couldn't understand. It was a surgery or it was only diagnostic, and it was very good, very big scare from the patient. And after treatment, he said, it was nothing. I just slid on the bed and went out from the angio suite. And I think the microsurgery, the one of the psychological part is a skin incision and staying in the hospital for 7-10 days. It's also psychologically a little bit stressful. And endovascular treatment is allowing to avoid this kind of part of the life, yes. And I really appreciate microsurgery is doing very good, but superficial AVM, grade 1, grade 2, including grade 3, nowadays, it's a 1 or 2 session of endovascular treatment with the respected rate of complications.
Thank you very much. Thank you. You see, we have been born in microneurosurgery, and we have lived in microneurosurgery. And we have on the way seen endovascular treatment, and we have seen endovascular treatment grow to a great extent. endovascular treatment has indeed created revolution in aneurysm surgery. There is no question about how the dural fistula surgery, 𝒂𝒂𝒃 fistula surgery, embolization, they have come complete revolutionary. But in AVM, do you agree that the treatment is still evolving? It is not, it is not final that yes, can be done. There are still controversies, there are still difficulties, there are still problems in embolization. And if you ask me personally, if possible, I will do surgery, and if not possible, I will say just hold on, don't do anything. So what is your take on this?
If it's possible, I will occlude the AVM endovascularly. If I'm tired, I will ask my neurosurgical colleague to go and to resect the AVM. Yes, but if it's possible, I will occlude the AVM, and at least I will prepare the AVM for the microsurgery. It's a situation in our department, and it's a neurosurgical department. And I showed the meningioma case also, and we started to occlude the meningiomas, and I think the saving the blood, and in different places, my colleagues has a very severe bleeding and need a hemotransfusion, and it's also the problem. There is infections, hepatitis, HIV. It's also might be the other part of complications, and microsurgeons didn't count that complications also.
Okay, thank you. So how about another question from audience? Dr. Kostadin, do you have any question? Dr. Ben, let's start your question.
Just
okay.
Question. I would like, these are formidable results. I mean, to the moment, really, we are not very clear where we are with the multimodal treatment and selectively with endovascular treatment around the world. So these results are really fantastic. What I would like just to mention is that I would like to know about more the so-called asymptomatic and non-bleeding AVMs, particularly the indications. I heard about pregnancy, but I mean, I would like to know, because the group was relatively big. And the second is, how do you follow the patients for recurrences after, particularly only after endovascular treatment? What is the protocol for follow-up, and when the decisions are taken for multimodal treatment?
Thank you. It's a very good questions. Yes, it's all the time the asymptomatic AVMs are a problem. And in our department, the indication to treat the asymptomatic AVM, it's the intranidal aneurysms. It's one of the first indications. It's a stenosis on the draining vein. If patient asymptomatic but has a stenosis on draining vein, it's a direct indication for the treatment, because during the follow-up, this AVM will bleed. And also, the patients are coming after neurologist. And if neurologist will say, you will die, you have a bump in your head, then patient will not sleep. Yes, it's a big disaster. They're looking for the conclusion of the MR and saying, you have a bump in your head. And this is also the indication to treat the patient. And concerning the second question about could you repeat your question?
The protocol for follow-up of these patients who have been
follow-up
treated.
protocol, yes.
Angios or MR angios or CT angios, whatever you do. I mean, what is the protocol, and how do you decide them for multimodal treatment? Which patients will go for additional resection, for radiosurgery, and so
on? If we completely exclude the AVM, or it's a partial treatment, there is no difference. We're asking patient to do MR angiography without contrast if it's a partial treatment, with contrast if it's a complete exclusion. after 3 months. And
3 months.
from 6 to 12 months, we are inviting patient for the control diagnostic angiography. And if everything is clear, we are asking patient to do control MR every year during the first 5 years. And then we can do control MR every 5 years after last 5th year's control. And about the multimodal treatment, if we see the remaining part is not more reachable for the endovascular, we recommend to go for microsurgery. It's the first. And in some cases, we prepare the patient for the gamma knife. And if there is a multiple draining veins, and it's a compact compartment less than 3 centimeter, we recommend patient to go for the gamma knife, and we are happy and patient are happy.
Thank you very much. Thank you very much. This more or less matches the current international criteria. Thank you so much.
Thank you.
Thank you so much. Almost time is coming, so I want to closing this session. So, Dr. Sharon, do you have any comment to this program?
Thank you so much, Prof. Kusumi. Actually, today I think the program was great. Of course, a lot of wise words from Prof. Atal Goel as usual to make us realize how far neurosurgery has come and how lucky we are today. I thank also our 2 other esteemed guests. Thank you so much, Ms. 𝑑𝒂𝒓. I think it was a fantastic presentation from your side, opening up our eyes to a lot of us microsurgeons on the options we have now. I think I'll just call Prof. Kato. Maybe you would like to say something, Prof. Kato?
Professor Kato, please give us your comment.
Yeah, I think you have some comments about the AVM, maybe?
Oh, you are mute.
No.
We
can't hear you.
Avidasha, you want to say something?
No, I think it was a fantastic webinar, and we heard a beautiful picture from the Grand Master of Skull Base, Professor Goel, and we saw some beautiful AVMs that were embolized. And Monali also gave a very good talk on radial artery access. And I'm not sure if how much of radial artery will now take over the femoral, because still there is some difficulty in navigating, but definitely it's a better route. So let's see what happens in the future. And Professor Kato, you may give you the closing remarks.
Okay. Thanks so much. So at the beginning, maybe Atul, thank you very much. He will be the 15th Asian Congress the president into the 𝒂𝒐 in Mumbai. Maybe I think he and the great assistant of Dr. Avidasha is thinking the detail of the Congress. I really appreciate. So the Goel is, I think, he is a superstar of the open surgery, I think. But I think in the future, because it's getting less and less of the who want to become the neurosurgeon or surgeon, so I think how we can educate them. But because the very rare the neurosurgeon, just like Atul Goel, I think maybe he has some responsibility. Maybe Avidasha also, I think, to teach the very precise, nice skull base training, and also the nice the surgical skill, I think. The second, the Monali, and also the guy from Kazakhstan, Minchi Halki, is okay? Maybe almost okay. Sorry. Now we have one guy from Kazakhstan. He is the great neurosurgeon in the future, I think. I think it's the time of the less invasive era, I think. It's very fit. But still the AVM, we need to think about the eloquent lesion and the large one. So maybe how we can treat them in a transvenous or transarterial. So maybe, of course, compartmental embolization is very, very fundamental, but I think you have a huge experience. Maybe it teaches again and again, please. And also maybe some of us will visit your country next year, that you have a nice Congress in English, you said. So we all are expecting your Congress. Almaty is it to reach through Beijing or through Korea?
I think there is a direct flight, but I hope Afzal will explain how to reach the Almaty and Astana. There is a direct flight from Seoul, but I hope there is a flight from Tokyo also.
Tokyo. Okay. That's nice. Okay, so thank you very much for the three speakers, and we learned a lot from you. Thank you so much, Sharon or Kusumi Sensei. Thank you very much.
Thank you very much.
Thank you very much, Prof. Kusumi, for being the chair today. I think it ran perfectly. Thank you, everyone. Hope we can see you all again in the next month with more interesting topics to discuss and continue to grow our knowledge and also to have more social interaction with each other. Right. So then, good night and see you all soon. Bye. Take care.
Okay.